hold these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office. Experts on what they're talking about.
This is the podcast
For insights into the issues.
China, bioterrorism, Medicare for all. In-depth discussions.
Breaking it down into simple terms. We hold
these truths. We hold these truths.
With Dan Crenshaw.
The Eagle has landed.
Hey everybody, welcome back. I'm honored to have Deputy Secretary of Health and Human Services with me, Eric Hargan. Eric, thank you so much for being on the show.
Good to be here.
Well, wow, this is your agency is on the front lines right now against the pandemic. And first of all, want to say appreciate all the hard work you and everybody there at HHS are doing. I know it's probably 24/7. So thank you.
Yeah, it's hard. Not as hard as Bud's, but it's hard.
And not as hard as, our lives are relatively easy. We're still getting our paychecks. We are, a lot of people's inconveniences are just staying at home. But there's a lot of people whose businesses are totally lost, out of a job. And, there's a real crisis in America right now. And the sooner we can get some kind of control and risk mitigation measures in on the pandemic, the sooner we can get back to some kind of new normal. And I know you guys are working really hard to help us get there. So yep. Again, appreciate it. The question on most Americans' minds continues to be testing. And I want to start from the beginning on what we first knew about this disease, how we first started to develop a test, why at first we were behind countries like South Korea. What did they do differently than us? And just what does it even take to make a test for a new novel virus like COVID-19?
Yeah, well, I think there you've kind of put your finger right on it. This is a new virus. So whenever there's a new virus that appears, obviously you have to have people develop tests for it. So these new tests that were developed, molecular tests that were developed in several locations across the globe, but also here in the United States, you have to be able to get it right. Sometimes that process, the nature doesn't cooperate, or the processes that are put in place don't cooperate. So people are developing these new tests right on the spot, trying to see that if they'll work. And of course, that now we have tests, lots and lots of tests, these molecular tests moving forward, now up to 150 to 200,000 a day, from, sort of a start of zero when this virus originally came in.
That's a huge number. I remember it was probably February when South Korea was ahead of us. They're doing 10,000 a day, and we were all looking at them like, how do they do that, and why can't we do it? We're the United States of America. Why can't we do that? Now we're doing 150,000 a day, at least. And as I understand it, we could probably do more. Some of it, we actually have more capacity than people aren't even asking for the tests to the extent that we can actually do them. So that's one part of it. But backing up again, like why does a country like South Korea, why were they able to do 10,000 a day? Was that because of their prior experiences with SARS and all this?
Oh, yes. Yes. So, they went through the SARS problem in 2002. And so they're very sensitive about the issue of having that capacity in place. They also have a system where they are able to require a lot more of their citizens directly. It's we're this United States. This is America. There's a lot more sort of cooperation and freedom here in that sense. So they're able to kind of go, we're going to go. You're going to be tested.
Yeah.
We're going to go into a place and you're going to be tested, and we're going to have particular requirements on people that isn't really part of the American system. So they have a different way of doing business over there. It's a democracy. It's a very free society, but they do have different rules and different expectations.
Yeah,
there.
That's very true. I did a deployment there, and it's totally different society. I believe they have ways to actually track people with QR codes. Is that correct? As far as their contact tracing,
they're able to track people much more closely than we would ever anticipate doing. in the United States. Absolutely.
Yeah. I mean, I remember being there wondering why everybody was always wearing masks. And this was back in 2016. I just figured it was for air pollution. But I might be wrong about that. Actually, I should probably know this, but because the air pollution was terrible. And I always wondered, I'm like, the mask doesn't prevent you from breathing in air pollution. So I'm not sure why everybody's wearing a mask. But in hindsight, I didn't realize that it was because of, or at least a part of it is because of their experience with pandemics.
With SARS in the past, yes.
And so in February, the CDC took the lead on building that test and ultimately failed and had to divert that responsibility to the private industry. I mean, what happened there?
Well, I think, we are continuing to do a thorough look at what happened. That about what happened in-house with these two agencies here at HHS with, on the one hand, CDC that was developing a test and having interactions with FDA, which was overseeing kind of the regulatory side of this. So they were working together on this, primarily CDC, but FDA was involved as well. We're digging in on that. Remember, we're going to have to take a thorough look at what happened, but we also don't want to divert the people who are doing the response by, sort of overseeing them in the middle of the response,
right,
and sort of pulling up on them and, what did you do and when did you do it, and kind of diverting their hours and their days.
Yeah, no, and I'm not saying we do an investigation right now by any means.
Primary response.
But just for people's understanding, I mean, it's and I've laid this out, and I think this has been pretty laid out in the media too, but maybe not enough. Which was, it's not as if we were just ignoring it. Is my point?
No.
Like there was an honest attempt to try and make it, and ultimately the test didn't work, and that's why we were behind a little bit.
Well, the test was corrected. The test ultimately did work. Once the private sector and innovators were allowed to innovate, we had tremendous success here. I think that is also something that we need to learn from this as well. Approaching it from a typical public health lens at the very beginning, and remember, at the same time, they're looking at what are the factors of this disease? How deadly is it likely to be? How contagious is it likely to be? They're trying to assimilate information that we're getting from China to try to analyze what they're supposed to be doing. And so they're working in a very typical way, a typical public health way, to move forward on a test, to move forward on finding out getting the viral sequence, working on a vaccine at NIH, and all those kinds of things. And then, fortunately, we have not just government resources, but the entire private sector. So when conditions and facts were better known, we were able to unleash all of our fantastic companies, and they have stepped up tremendously to provide the amount of testing capacity, and are continuing to add it on, different kinds of tests, new tests all the time. And so, we will likely, I'm not going to promise on behalf of private industry, but we're likely to get where we need to be and where everybody, I think, expects us to be.
Well, and where is that? I mean, 150,000 tests a day, that's pretty massive. It's more than any other country by far. On a per capita basis, I'm not exactly sure where we're at. I think some countries still beat us on a per capita basis, but it begs the question, I mean, what is our goal, and why is that our goal, and what's the right strategy for testing?
Right. Well, I think we're always going to lose out to Iceland, say, which has a lab there. Per capita, I think we're going to lose out to them. They have a little over the population of Des Moines. So we are absolutely, I don't think we're ever going to get to the per capita testing, molecular testing, I should say. So that molecular testing that tells you, do you have the virus in you right now? Those are relatively somewhat complicated tests. They're kind of the gold standard of testing, and that's what we're doing right now. If we're going to move beyond that to different kinds of tests, the ones that people hear about, the antibody tests that show, have you been exposed to the disease and do you have immunity? That's the new phase of tests that have been developed and are being tested out. And those kind of tests are able to be produced by industry in many greater numbers. The molecular tests are little bit more complicated. They take more time. Just the way that the equipment and the labs are run makes it a little harder for them to be sort of cranked up.
Yeah,
There's
a scalability problem there.
There's a scalability issue with those. The serological tests, the antibody tests, are hopefully will be available in many greater amounts. We'll have other issues with them as we move forward, just generally with antibody testing, but they will. I think that's what people have been trying to figure out is, will people be able to know, are they immune yet? Do they feel safe to go back into society? And that, I think, is the ultimate goal of this testing issue. Because, of course, the ultimate goal is that people feel safe going back into society and working and socializing and all those things, and not staying at home all the time under stay-at-home and lockdown orders. And that's going to mean that there's going to have to be a matter of public confidence coming back outside again for a lot of people. Some people, as you well pointed out, really want to get back in work, back into society, but a lot of people are still very cautious about what's going on out there.
Yeah, and understandably so. My intuition is that a lot of those people can work from home and can probably continue to work from home. And so I think how your economic situation is changes your perception on whether you want to go back outside to an extensive degree. And I think it's important for people to understand what you just said about the scalability. There's kind of a narrative out there that if we just wanted it badly enough, or if we just allocated enough money, which was kind of the debate in Congress this week, that all of a sudden we would just have all the tests we need. It's just not that simple. There is a scalability issue and a manufacturing challenge that occurs with these complex molecular tests, as you described.
If you want them to be accurate, done well, and these kind of tests just are by their nature more complicated. Now, this is all the information we're given in here at the department. These things take time. Scalability is an issue, and we have networks of these labs around, and we're able. There's going to be more attempts. You've seen them out there to sort of ship tests to different labs that have more capacity, and that can help move those numbers up, but not to that tremendous degree that people are thinking about. If their ultimate goal is, these hundreds of millions of tests every day, that's much higher than we could attain in any reasonable period of time for that sort of molecular testing. Yeah. Other kinds of testing, we'll move into those other ranges. You've heard those being sort of previewed on the press conferences.
Yeah, the serology
these
tests.
Other kinds of tests. Yeah, the serology tests, the antibody tests.
The antibody tests. And that kind of gets to the next question then. So at a certain point, we'll reach a goal of a number of tests. But then the question is, how do we deliver those and who takes those tests? Because right now, we're not doing as many tests as we even have the capacity to do. So we can keep producing more testing capacity, but the truth remains that at least in some parts of the country, we can open up, hey, come get your test right now, and not that many people will show up. We see that in Texas, for instance, where listen, it's unless we tell you to get a test, we can't force you, and so this gets to what's the right way to even look at testing as it pertains to our overall strategy? Because I think there's been a lot of misconception on this. It's almost as if people believe if you get a test, it's, that helps you prevent the spread. And I'm skeptical of that notion. It doesn't seem like that's the right way to think about testing.
No, it's not. I mean, early on in this, obviously people were talking about testing. I had, relatives of mine coming to me and say, I want a test. Give me a test. They all wanted to have the test. And, of course, they see me. I'm an HHS official. They just imagine I'm going to, start handing out tests randomly to, family and friends. And, of course, that would be a really bad idea for me to do. And also, it's also the case that it wouldn't help them in many cases, because what are they going to do? Take a test today and then again tomorrow and then again the next day, because they could have gotten infected, taken the test in the morning and gotten infected in the afternoon, and so on.
It's a snapshot.
So Exactly. So you to sort of say for this sort of first type of tests that were produced successfully, they show you whether you have the virus in you. In most of these cases, these molecular tests are doing that. So you would have to take a test sort of all the time to see whether you had it. That's not really the kind of test I think that people are looking to. That's the test that, it's important, no question about that. But I don't think that's what people really want to be doing daily. So that's not really the solution. And it was, but I think because they were the ones that were available, people start saying, well, that's what we need, because that was
Right.
what was available. So what's the ultimate solution here? Some of it is going to require us to see, some of it's going to be exactly what's going on, I think, right now. People are going to have to think through what are the risks of going back into society, to look at those elements that have been laid out on that kind of, some of the guidelines that we've been putting out in the administration on opening up America again. Look at those guidelines and people to kind of analyze them, state and local leaders analyze them and say, go through those elements, say, what kind of cases am I having right now? What's the outbreak here?
Right.
What are the sort of risky areas, the essential areas that we have? How's my healthcare system doing? Remember, initially we're flattening the curve, the now famous phrase. That was in many cases meant to make sure that our healthcare system didn't get overwhelmed, that we didn't have so many cases arrive all over the country that we overwhelmed the healthcare capacity. Well, now we've spent a lot of time, and the system, the healthcare system and the suppliers have spent a tremendous amount of time, and we have as well, procuring supplies, getting them into production, and getting them in the hands of providers so that they wouldn't be overwhelmed. So at some point, that has been achieved, or we can have some hope locally when they analyze it, say, well, maybe it's time for us to open up. At that point, it's those public health recommendations, those guidelines, the basic hygiene, the social distancing, those kind of things, and testing also. You can see that laid out as well, that we've kind of moved to see, are you immune, are you not? And that's where we see how much of this has gone into sort of location by location. Some places are going to have more people exposed, some places a lot less. And I think that's just going to be where we go as we move towards eventually, God willing, a vaccine.
Yeah, and it would seem to me that the right way to think about testing, so let me just use my own hometown here in Houston as an example, where if we did an antibody test for everybody in the city, I think it'd be doubtful that we'd have a huge amount of people with antibodies, just because we've never really had big outbreaks here. Our numbers have always been low, but where we obsess over the curve, even though the absolute values under that curve are very, very low. And so this is kind of a problem I see with the general thinking about what we're doing. Our hospitalizations are very low. Our hospital capacity is very high. So, does that tell us that we've maybe overdone it as far as keeping people at home and keeping everything closed? We don't have everything closed to the extent that, say, California does or New York does, but there's no traffic. How about that? And for Houston, that's pretty weird. So,
Right.
It would seem to me that, and we have this overcapacity of testing. Okay, so we have more tests available than people are willing to go get them. They are free to go get them, and they're not getting them. But what the purpose of testing, as I see it, is basically a surveillance system to identify future outbreaks. And
Right.
I feel like that hasn't been talked about enough. I think we all understand that, but we don't all understand that. I think experts understand that, but it's not clear to me that the media understands that, or that even local leaders understand that. They just keep saying more and more testing, and then we can get back to work. And that's true, but you have to use the testing correctly. And does that mean public-private relationships with businesses? Do businesses do periodic testing with a few samples of their employees? Is that the best way to go about it? Like, how do you think what's the strategy here?
Well, some of that is going to be private industry for sure. In other words, they want to feel some surety about having their workers coming back into the store or coming back on the factory floor or wherever. Absolutely. And you've seen that happening business by business. Some of those people have done that. Some of it's going to be probably government sponsoring public health surveillance as well, because local leaders, as they move to try to open these things up, again, it's that element both of the leadership and also the public confidence that they can move forward. And some of that is going to be having that testing capacity available to see, is an outbreak happening? As I open up this town, as I open a county or a state, that you maintain a watchful eye and the capacity to have a watchful eye on the situation on the ground to see, is this coming? Is this coming here? Am I getting an outbreak? Am I getting another outbreak? And where is it? So you can try to address that locally and figure out whether it's happening or not, because that's going to inform whether or not you go back into a situation of, more distancing, less, and that's that flexibility that's going to probably be necessary, both from the point of view of addressing the disease itself, and the suffering that it imposes, but also the economy opening, and obviously the suffering that the lockdown imposes in its different way than the disease.
Yeah, and that's absolutely right. And I know here in Texas, I think that's how we're thinking about it, or I'm encouraging local leaders to think about it. Like we're developing a system of contact tracing, where we're training people up to do that contact tracing. I've heard of medical school students being recruited into that. Seems like a great idea that could be that could be reproduced around the country. And, it seems like the federal government's role in all this is to build up that capacity, which is the most difficult thing to do for reasons you just mentioned before. Scalability of this unique testing thing it's not just a matter of throwing more money at it. It takes some time, but it has to be implemented in a strategic way at the local level.
Yeah, it's both where if you have testing capacity, as you mentioned, Houston might have more testing capacity, but New York, where the hotspot is, needs to get, if they were going to access that testing capacity in Houston, that would involve a whole coordination of bringing things to Houston, shipping them back. That can be done, but it's another level. And in the meantime, maybe Houston would have an outbreak and they would need it there themselves. Yeah. So these are always questions about is the testing capacity really there? Where does it need to be? So those will be questions. If you say, hey, we should build some more testing capacity, that's one thing. Another thing is these sophisticated tests need laboratory personnel to be able to do them, to be able to interpret them. That's its own other area. Workforce, it's not just money, it's not just building, it's not just ramping up testing production, it's also interpreting the tests, administering the tests, making sure that they're done validly, because they're often very complex tests in and of themselves. So it's a far more complicated question, I think, than people realize when they call for more testing. There's a lot behind that. Not to entirely apologize, but for the situation that we found ourselves in. We were in a situation of a new virus, and I think the complicated ways that the disease has kind of shown where the bare patches were in an epidemic response, I think is something we're going to be analyzing for a long time.
And should we expect more federal guidelines and just guidelines, not specifics, but how for local governments on how to implement that strategy? So let's say Houston gets to a point, and with help from the federal government, that we're doing 10,000 a day here. Okay, let's say we get to that point. We're not there yet. We're like a couple thousand a day, which again we don't even have enough people to take those tests. Or it depends on the day, really, I should say. Sometimes it fills max capacity, sometimes it doesn't. But will there be federal guidelines to sort of suggest to localities what to do with those tests once we've reached what is a good number? Again, looking at, hey, we suggest you have certain industries do sample testing once a week with certain employees. We suggest that a school might do sample testing once a week or every few days with different students and different teachers. Are there going to be suggestions like that coming out?
Well, we are preparing guidance pretty continuously for all different segments of society, and that while I can't confirm one particular, local school districts, it would surprise me if CDC doesn't do those exact things, or work with states to prepare those for local school districts. In other words, sometimes really the federal government helps states deal with localities as opposed to doing it ourselves. It would surprise me if we don't have those out there at some near point.
And it seems to me that states are already doing it. Like I said, I already described basically how we're thinking about it here in Houston and in Texas, and that should be the case. But I'm also seeing mostly just all over the news how easy it is for local and state officials to just throw their hands up and blame the federal government, which I find to be a total, kind of a, how would I describe it? It's just a removal of accountability in the worst of ways. And I find it to be terrible, but that's what's happening, unfortunately.
Well, people who are in this area know that an epidemic response needs to be local. When you look at how the country addresses disasters, say like hurricanes, you have an area that's geographically limited. And so it is possible to have a national response that draws resources from unaffected areas. So if you have a hurricane that strikes Houston, then Houston is in trouble, but that same hurricane doesn't hit Salt Lake City, Minneapolis, Cleveland, Boston. Mm-hmm. So we can take federal resources and bring them to Texas to address an issue. So those kinds of disasters that strike a local area, those kind of responses, really the federal government can do that. When you have an epidemic, generally the doctrine is that states and localities generally have to confront those locally, much more primarily because you don't know whether the disease is going to move from one part of the United States to another. Do you take resources from Chicago, send them to Houston, and then find the outbreak the next day travels to Chicago?
Right.
So that's why in an epidemic response it's slightly different, and so local responses, local resources are often incredibly important. While the strategic national stockpile on the federal government role in that is really important as a backup, it's always going to be necessary for the states and localities in disease outbreaks. It's going to be proportionally more local.
And you bring up the stockpile, and I wanted to hit on that also. There's a lot of criticism out there that we underprepared our stockpile, and it's all Trump's fault. That's always what you hear. So what's the truth? Who manages the stockpile? How do we think about what we put into the stockpile? Was it really underfunded? And what's the history on this thing?
Well, the stockpile is it's managed here at HHS in our Office of the Assistant Secretary for Preparedness and Response, or ASPR. They're the ones that sort of buy and manage the stockpile. They procure things for it. CDC had it. It's transferred to ASPR now because they do, as I say, our preparedness and response. So stockpile is there. Now, the stockpile is available for all kinds of different things. They have to plan for all kinds of potential problems on that. So it can be chemical, can be, a bioterror attack, radiological, nuclear, a natural disaster like a hurricane, and epidemics in all their different array. For everything, the epidemics can be all different kinds. So, for example, we had the stockpile really started to acquire things like devices and those kind of things when I was here under President Bush. Mm-hmm. So we were looking in the wake of 9/11. And you had to look at a different kind. It had been a pharmaceutical stockpile primarily, but you had to look at a whole different array of threats. And so we articulated this range of threats, the CBRNE, the chemical, biological, radiological, nuclear, epidemic range of threats and natural disasters to see what do we need to do here. They all have different responses. So, for example, things like ventilators and masks and so on are good for respiratory diseases, but what if the outbreak is something that's a GI problem, or what if it's a hurricane? You don't really need ventilators if there's a hurricane, but what you might need in a hurricane is you need maybe those, federal medical tents and mobile shelters to be there because the hospital got annihilated or by a hurricane or something like that. They're all different. So you have to plan for all those. The people who run the stockpile have to plan for many different sets of possible issues.
Yeah.
So that regardless of the administration, I mean, Republican, Democrat, or indifferent, they're going to have to plan for a full array of these things because any one of them could happen.
Right.
So that's what they try to do.
And to that point, as I've noted, we had a 75% decrease in N95 masks after the H1N1 virus, which was under the Obama administration. And the question is, okay, do we blame them? Do we blame them because we don't have enough N95 masks in the stockpile? And I said, I'm not so sure we blame them. I'm not so sure they had this crystal ball that they would need more. And, I'm not sure what the CDC, because at the time CDC was in charge of the stockpile. I'm not sure what they thought the next big threat was and what they were preparing for.
Yeah, you'd have to ask Dr. Friedman. I mean, I've seen him talking about the response, so you'd have to ask him why what they were facing. And I think they probably have answers to that. In hindsight, they may go back and wish they had done differently than they did, but that's going to be part of the after action as well, is to look back and see, what did they spend their money on? And it's going to be one of these range of threats that they make an analysis on.
Yeah.
And most of the time those are done in a pretty thorough, scientific, public health informed way. It doesn't mean that they were right for every particular circumstance. Running down those respirators, that in retrospect, they would probably go back and think maybe we should have not done that. But that's, again, hindsight.
Right. Yeah, I mean, the ventilator issue that was really front and center in the news for a while as this fear was being perpetuated that we were going to run out of ventilators. Of course, we never did. We ended up having much more than we needed. And even pre-crisis, as a country, our healthcare system has far, far more capacity when I've broken down the numbers than any of these other countries like the UK or Canada or European countries, specifically with ventilators on a per capita basis. We've had far more.
Yes. Far more. I mean, you look at a lot of those things that United States puts a lot of effort and resources into the healthcare system, and that's one of those examples where we had a lot of capacity. Was that capacity everywhere there was an outbreak, in every single neighborhood where there was an outbreak and where doctors wanted to use a ventilator? I think, we heard that, strongly that was not the case. But a lot of those we were able to get that capacity together and bring it to where, and have been working to bring that where it needs to be. And now we're going to have a lot of ventilator capacity in this country.
Yeah. I mean, to this day, I'm not aware of any cases that somebody didn't get the care they needed. We don't want to go step out on.
I don't want to rule on every case. That's for sure. But that again is going to be something we're going to have to look at in hopefully, God willing, we get on the downslope of this crisis and we say, where did kind of this outbreak kind of put its fingers through the walls of what we had prepared, realizing that we started this, 15, 20 years ago, is building a foundation of preparedness. And I can say, if I look back on things that we were doing in the Bush era and the responses that were had in those days, we have come a long way in preparedness. There's a lot of things that I believe, it's just me speaking, we did better here. There's a lot of communication early on that happened that was different than what we were having back in those days. It was, who's doing what. There's a lot more clarity, not perfect clarity, but a lot more clarity. There were a lot of things there that weren't there in the past, and that is an achievement. Was it enough? I think people say it's not enough, but 3-4 succeeding administrations have built this system out, and we're going to obviously be undertaking a scrub I'm sure you all in Congress will as well, to see what was done right and done wrong.
Well, the hard part about this is how to remove the political opportunism from that scrub, because President Trump is president. The obvious reaction is that everything could have been prevented, and it's all the administration's fault. But if you're trying to be an objective, critical thinker, the right way to think about hindsight criticism is what we could have done reasonably different. Not different. I mean, in hindsight, everything's 2020, and you would have just done a number of things differently. But talking about what was reasonable, what could have reasonably been done differently, is actually a very, very different question, because you do have to prepare for all unknowns when you're talking about disaster preparedness and pandemic preparedness. That seems obvious, and I think most people would agree with that if politics weren't involved, but they are.
Yeah.
So that's the unfortunate.
But here we are. Here we are.
That's the unfortunate reality.
Yes.
What about regulations? Your HHS is in our healthcare system as a whole has a lot of regulations. I mean, it's pretty mind blowing, and we've waived quite a few of them recently. Things like specifically with telehealth and doctors being able to give people the care they need to give without fear of some kind of being some liability or going across state lines. And it really begs the question: why were these regulations in there in the first place? Like what? How can we go forward here?
Well, what I think here is that regulations are kind of my sort of home territory in here. That's a lot of my background, both from Bush era and then in the interim. And I really think we have to build on what we've already started here in this administration. Point of pride for me is that HHS has been the number one deregulator among the departments for the last 2 years. And, now I think we've seen recognition of how this attitude in this administration has informed us. We've responded to an emergency like this not by regulating, by taking more power, but by deregulating and helping unleash the free enterprise system. Hopefully we're making sort of room on the books, but not so that we can add more regulations in the future. We look at a lot of the individual examples, things like these telehealth restrictions were probably too burdensome. I think that in 2 months, the country has advanced, in my estimation, maybe 7 or 8 years in terms of where we were in telehealth. And, a lot of that was because a lot of people didn't want to go on site at a hospital or a clinic. They're worried about the infection. And so they, on the spot, doctors, hospitals, patients went for telehealth and telemedicine in a really big way. And I think a lot of people think we should keep the current policies in place. So we're probably going to give that due consideration. I mean, I grew up underfoot in a rural hospital outside a town of 800, deep southern Illinois. And, that the state of rural health generally requires, I think, a lot more thought about embracing technologies like that. Things like that, the interoperability rules that we put out that, again, try to advance digital health, telehealth, electronic availability of health information and access to it. And I think we could be in a really good place in the near future in terms of the access of information and services, particularly in the sort of vast rural and remote parts of our country, but not only there. I think that would be an example of how we can respond creatively to this and really take what we've already moved forward on in terms of deregulation and unleashing the private sector and just amping that up.
And so outside of coronavirus conversation, I mean, what would be the top 3 or 10, give me as many you want, regulations that you would change just to make our healthcare system better, whether cheaper, more efficient, whatever it is?
Well, some of it has to do with the ability for people to use sort of common sense telecommunication technologies, the way that people communicate today in many ways over their phones by video. That's something that there are regulatory issues with that, because is it encrypted? Is it secure enough for people to kind of look at, for a doctor and a patient to talk face to face, or for a patient to kind of say, oh, I'm going to show you a picture of my rash or video of a rash, say, because you can see that on video, things like that. So that some of that has to do with HIPAA and the flexibilities that have been introduced for people to use sort of video communication, email communication, even audio communication to deal with their doctor. For people to, for example, some of these things that we're dealing with, trying to make sites of care a little bit more even and accessible so people can use local, say, surgery centers, and people can take advantage of that, for non-hospital buildings and spaces to be used for patient care, to allow people to receive care at home using remote patient monitoring technology. So monitoring technology that could be used in the home, things where people can kind of do better coordinated care. So we're advancing some regulatory initiatives right now, allowing there to be sort of these patient engagement tools to be given to patients so that they can sort of do their own care at home or communicate with their doctor. If they have a digital scale, so they can step on it and it transmits their weight directly to the doctor instead of them having to come in and be weighed themselves. That creates its own set of problems. Otoscopes that can be given out remotely so people can, a mother can monitor her kid's ear infection and send that in directly to a doctor. Some of those things, removing barriers for physicians, nurses, so that they can be hired and practice to the top of their license, so that they aren't sort of artificially constrained by licensing regimes, that that we're not adding federal layers of regulation on top of that, so that they can practice fully to the extent of their training to get that. So those would be, and also some of these relief from the auditing and reporting requirements that are really overly burdensome in the system right now. There are ways we can do that. Those auditing, reporting, the quality reporting system. We were already standing out on that, on this quality roadmap. It's a really complicated area, but it has developed and accreted over time. And I think the system is ready for a lot of these reforms. And that's where I think we could head. I think that maybe that was more than 10 that I was listing there, but that would be an example. Sorry to give you too much of the the weeds, little weedy there, but
no, you need it. And you can kind of categorize this the following way. It's essentially more freedom to get care where you want to get it. The sort of, because you mentioned sort of freestanding clinics and, just allowing more competition in the market, allowing doctors to just start a practice without dealing with some of the problems that they currently deal with. Like, okay, if you're a physician, you can't own your own practice. There's this idea of physician-owned hospitals or physician-owned points of care. That's an issue. The telehealth thing seems so common sense, especially if you're a millennial and you're my age. You're just wondering, why can't I just look at my phone and look at my zip code and start flipping through doctors? Why can't I do that? I think everybody has that question, and it should be rather easy to do. Again, just more choice, more competition drives prices down. Because what's the number one problem in our healthcare system? It's just too expensive. It's too expensive. Yeah. We have the best. It's very obvious. You can't argue we don't have the best. We clearly have the best. We have the most innovation. If you have a real health problem in the world, anywhere in the world, you want to be in the United States. Yes. Period. But it's too expensive, and that means access is decreased. And so, figuring out how to remove regulations to increase efficiency and decrease expense is it's really got to be what our main goal is. One thing I'm working on is direct primary care. That's my favorite thing that I want to keep pushing and figure out how we can expand the use of direct primary care. And I think that's, it does all the things you're talking about. It's engaging in telehealth. It's a doctor-patient relationship. It is something where you could look at your app and choose between doctors and pay $75 a month and have full access to a primary care doctor. And like that has huge benefits down the road.
Yeah. And some of this is going to be regulatory work that we can do here at the department. Some of that, no doubt, is going to be legislative work you all are going to be doing there in Congress to try to move these things forward to where people, I think, want us to go. And I think that this current crisis has really put a point on that for where we need to go, where we have to go in this system.
Yeah. It's it actually, in hindsight, as we look at lessons learned from the pandemic, I can't think of one lesson which says, wow, we really should have had a regulation on that. I mean, I could be wrong, but I don't think there's an example.
That's a sea change from where you would normally see the government respond, is to say, we've got a crisis. Normally that for most of our lives, the answer would have been, we need more regulation or we need more control. The fact that we've responded as a country, we've deregulated here in the administration, we've deregulated generally in this country, and that part of it has been effective. And I think that has to be one of the central lessons learned about what we did here.
Absolutely. Last question I want to bring up to you before you go. And I'm not really sure if this is in your lane or not, but there's a lot of talk about bringing supply chains home, and with our medical supply chains and our drug supply chains home away from China, so we're not totally reliant on that. Is that something y'all deal with at HHS? And do you have any ideas on that?
Sure. I mean, some of that is going to be dealing with general issues that deal with the more economical departments, the people that deal with trade and commerce,
right.
that side of the world. So some of that's on there, but generally, I mean, you may not know, we've been here before in 2004, in October of 2004, we lost half of our flu vaccine supply in this country. A British company was supposed to export us half of our flu vaccine. They had a problem with the vaccine. It was unsalvageable. So we lost half of the flu vaccine. Now, normally here at HHS, we have to beg everybody to take the flu shots.
Mm-hmm.
But once people knew half the flu vaccine was gone, absolutely everybody wanted it.
Yeah.
Right. So
yeah.
there was an immense rush to get those flu shots that we normally beg people to get. So there was, at that time, we put forward the idea that we needed to onshore vaccine manufacturing capacity, and we were going to set out plans to sort of create warm bases and have all these vaccines. Now, some of that stayed and some of it did not. Some of that attitude stayed and some of it did not, because over time, people, being human nature, they lose the idea that this is important, and that I think that's going to be something we're going to have to really grapple with and understand how we maintain kind of a better and more permanent capacity here that can respond effectively to needs of this country, to respond to things like medical emergencies.
Right.
Because yes, you saw it here. This is absolutely an example, but we've been here before. And I think, we're going to have to, this is not a new thing exactly. It's new in the amount of problems that have been imposed, but it's not the only time we faced this before. And we have to look at what we did before and why over time, some of it just being human nature, did we sort of stop our focus on some of these preparations. So that's an issue.
Well, we have a short-term memory. That's why. There's your psychological response. And it's funny. 2004, there was the run on flu vaccines, and in 2020, it's a run on toilet paper. This is where we are. Go. I mean, scarcity has an interesting psychological effect, doesn't it? I mean, yes,
it does.
Yes, it does. And marketing and toilet paper and flu vaccine. It is fascinating. As has this conversation. Is there anything else you want to add before? Because I know I want to be respectful of your time.
Oh no, I think this has been a great conversation. I've really enjoyed it, especially all the time and attention that you take in paying attention to the details in this area. I think it's going to be important for us to keep all these lines of communication open. I think there's a lot that we can learn about what has been done here as we move out of the response mode and start moving into more fully understanding, remembering the lessons learned that we've had before, and trying to figure out what we're going to have to do better on as a system in the future. And I mean, I think this is going to be a good opportunity, as we've been talking about, for us to do some things that are going to have a permanent positive impact on the country and on our healthcare system going forward.
I hope so. And